Welcome back to the Deep Dive. Today we are strapping in for a very deep and technical exploration of the androgen receptor system.
Uh-huh.
If you're getting ready for clinicals or maybe catching up on some oncology mechanisms or you just really want to master endocrine pathology,
Yeah,
this is for you. We've pulled together some foundational research to really get this.
that's exactly right. Our mission here is precision. We really need to move beyond just naming hormones.
Right.
We want to extract the mechanistic why. Why is the androgen receptor, the AR, such a central control point for, well, everything from sexual differentiation to the toughest cancers to bone health, even metabolism?
So we're breaking it all down, the
Right.
core mechanisms, the pathologies, and the pharmacology.
Exactly. We're translating that dense scientific detail into clear clinical takeaways.
Okay, let's start at the beginning, the production line. The major player circulating around is testosterone T,
Right.
and that's primarily made by the Leydig cells in the testes. Now, beyond its, obvious roles, it has two absolutely essential functions. It induces virilization of the internal sex organs. We're talking the epididymis, the vas deferens, and it acts as the main brake pedal for the entire hypothalamus pituitary testis, or HPT, feedback loop.
And that whole production line starts with one single building block, cholesterol.
The universal precursor.
It is, but this whole steroidogenic pathway is just an enzymatic assembly line. And the very first step, the real gatekeeper, is when an enzyme called CYP11A1 cleaves cholesterol.
And that gives us pregnenolone, or P5.
That's it.
So once we have P5, how does the system, decide what hormone to make?
Well, P5 hits a fork in the road. It can go down one of two main pathways, the delta-4 and the delta-5.
Okay.
Essentially, a bunch of specific enzymes, cytochromes P450 and hydroxysteroid dehydrogenases, determine its fate. But, they both converge to produce these key intermediate androgens like androstenedione. The number of enzymes involved here is just staggering.
And speaking of enzymes, let's dig into that nuance, specifically the 17 beta-HSD family. There are, at least 11 of them?
At least. And what makes them so crucial is their dual action. They're bifunctional.
Meaning they can build up or break down?
Exactly. They can catalyze a reduction reaction, which forms a potent steroid, or a dehydrogenation reaction, which inactivates it.
So that's how the body fine-tunes the signal in different tissues.
It's a perfect example of local control. I mean, take testosterone formation itself. Converting androstenedione into T is a reduction, and that's handled by 17 beta-HSD types 3 and 5.
But if a tissue wants to shut the signal off...
Then type 2 does the reverse, the inactivation. And the clinical insight here is huge. A deficiency in just one of those isoforms can cause massive hormonal imbalances, even if your systemic T level is normal.
Because the local concentration is completely out of whack.
Precisely.
So once T leaves the factory, let's say, and gets into peripheral tissues, it gets modified. And this brings us to its most potent metabolite, DHT.
Dihydrotestosterone.
Right.
Generated by 5-alpha reductase. And you're right, its circulating levels are only about 1/10 of T's, but it is a much, much more potent androgen.
And that's where you see the strong local action, right?
Yeah.
Prostate, skin, hair follicles.
Yes, and we have to distinguish between the isoforms of 5-alpha reductase. Type 1 is mostly in your sebaceous glands, think acne.
Right, oil production.
Type 2 is the one we usually link to pathology. It's in the prostate and hair follicles, which makes it the main target for, BPH and male pattern baldness therapies.
But T doesn't only become DHD. It can also be converted into estradiol, E2.
Through aromatization, yeah. The enzyme CYP19 or aromatase does that, mostly in peripheral tissues like fat.
And we think of E2 as a female sex steroid, but it is absolutely critical for men too.
It is. We'll definitely come back to that when we talk about bone health.
Okay, so let's look at the master switchboard then, the HPT axis. The hypothalamus kicks things off with GnRH.
Which tells the pituitary to release LH and FSH. Now, follow that LH signal down to the Leydig cells. It binds to a G protein-coupled receptor, which activates adenyl cyclase, and you get this huge surge in KMP.
And that CANMP surge, that's the second messenger that really turns on the cascade. It stimulates protein kinase A, or PKA.
And PKA does the heavy lifting. It phosphorylates the transcription factor CREB at a very specific spot, serine 133.
So that whole chain GnRH, LH, AMP, PKA, CRA is what ultimately controls the expression of those key steroid-making genes like CYP11A1.
That's the one. And the clinical insight. This whole cascade is incredibly vulnerable to stress. In critical illness like severe burns or sepsis, this whole pathway gets shut down by inflammatory
And
cytokines.
T levels just plummet.
They drop almost instantly to prepubertal ranges. Understanding that specific phosphorylation path is key to understanding how the body kills the anabolic engine during a crisis.
Okay, so we got the production line. Let's look at the switch itself, the androgen receptor. It's a nuclear receptor with 4 key domains. Can you walk us through those?
Certainly. So starting at the beginning, you have the NH2 terminal domain. This contains something called AF1, the ligand-independent activation function.
Independent, so it can work even without the hormone present.
Correct, often by recruiting other proteins, coregulators. Then you have the DNA binding domain, the DBD, which physically grabs the DNA. After that is a hinge region. And finally, the ligand binding domain, or LBD.
Where T or DHT actually dock.
That's right. And the LBD also contains AF2, which is the ligand-dependent activation function.
Now, I remember that AF1 domain is structurally really important. It has that polymorphic glutamine repeat, the CAG repeat. What's the clinical impact of that?
It's hugely significant. That CAG repeat is unstable, and we know that longer repeats lead directly to reduced AR function. This is critical, not just for normal variation, but for a specific neurodegenerative disease we'll get to.
Now, usually we think of AR action as genomic making new proteins, which takes hours. But androgens also have these like lightning fast effects, don't they?
Oh, absolutely. These are the non-genomic actions. They happen in seconds or minutes, completely independent of transcription.
And they use the conventional second messenger systems.
Exactly. The usual suspects like calcium flux or the MAP kinase pathway, the AR acts almost like a growth factor receptor on the cell surface.
Can you give us a solid example of that?
Sure, look at bone biology. In osteoblasts, when T or DHT binds the AR, it rapidly activates SRC kinase and ERK, which is part of that MAP kinase system.
And that does what?
That cascade is directly linked to anti-apoptotic effects. It saves the osteoblast from dying. And this is crucial because it shows androgens can have these vital biological effects that are completely separate from their classic, slower transcriptional job.
This speed, this duality, it makes AR function so dangerous in oncology, especially in advanced prostate cancer. Let's unpack that oncogenic crosstalk. How do growth factor pathways hijack the AR?
It's a truly vicious cycle. Growth factor signaling, say from HER2, enhances AR transcription even when androgen levels are super low, like after chemical castration. This is mediated by ACT.
ACT is phosphorylating the AR directly.
Yes, at specific sites, S213 and S791. So if a tumor loses the suppressor PTEN, which is very common in aggressive prostate cancer, activity just runs wild.
Which means the AR is constantly getting a go signal from the growth factor pathway, completely bypassing the need for testosterone.
Precisely. And that brings us to the want beta-catenin pathway, which is, I'd argue, even more insidious.
How does that one work?
Want signaling inactivates an enzyme, GSK3, that normally destroys beta-catenin. So beta-catenin builds up, goes into the nucleus, and acts as a massively potent co-regulator with the AR.
And that's the aha moment for clinicians fighting resistant disease.
This is it. Certain mutations, like beta-catenin S33F, can make the AR system hypersensitive. It allows the tumor to survive and grow just by using the weak adrenal androgens like DHEA that ablation therapy doesn't even touch.
You've taken away the main fuel, T, but the tumor just adapted to run on the fumes.
Perfectly put.
And that transition from hormone-sensitive to hormone-refractory prostate cancer is the core clinical challenge. We know BPH and prostate cancer need testicular androgens to get started, but then the tumor just figures out how to keep the AR turned on.
Yes, often through gain-of-function mutations that let it be activated by, well, almost anything, even the antiandrogens we use to treat it.
But the pathology doesn't always start at the receptor itself. You can look upstream, right, at congenital enzyme deficiencies.
Exactly. Deficiencies in enzymes like CYP21 or CYP17 lead to various forms of congenital adrenal hyperplasia. These often show up as severe salt wasting or ambiguous genitalia because the steroid pathways get rerouted.
And then if we shift downstream, we get to the receptor defects, like androgen insensitivity syndrome, AIS.
Right, which is caused by AR gene mutations directly. And that leads to a whole spectrum of undermasculinization, from complete AIS, where the body can't respond to T at all, to partial or mild forms.
Let's loop back to that CAG repeat you mentioned. When that expands.
Over 40 repeats, typically. That causes Kennedy's disease, or SBMA. It's an X-linked motor neuron disease. The expanded repeat makes the AR protein misfold, which reduces its function and creates toxicity in motor neurons.
So those patients show signs of androgen insensitivity, like gynecomastia.
and reduced fertility, even with normal T levels. The AR itself is just broken.
Okay, let's pivot to a totally different system. Bone health. Androgens are generally bone-sparing, right? They're anti-resorptive.
They are. They block the formation of bone-destroying osteoclasts and encourage them to undergo apoptosis, but there's a key finding here that often gets missed.
And that is?
While T is important, the major driver of age-related bone loss in men is actually low estradiol levels.
The E2 that's derived from T via aromatase.
Exactly. Studies are unequivocal on this.
Yeah.
If you inhibit aromatase in men, you see a much greater, much more detrimental impact on bone turnover than if you just lower their P. The protective effect of testosterone on the male skeleton is largely mediated by its conversion to E2.
So if you block that conversion, you risk osteoporosis, no matter how much T is floating around.
That's the critical point.
All right, let's talk pharmacology. Since DHT is the big culprit in prostate enlargement and hair loss, targeting 5-alpha reductase is a primary strategy.
It is. The 5-alpha reductase inhibitors, or 5-ARIs, are designed specifically to cut DHT production.
Finasteride is the classic example.
Right, it's a specific inhibitor of the type 2 isoform. For BTH, it can reduce prostate DHT by 90%.
90, wow.
Which causes the prostate to involute. And in androgenetic alopecia, it increases hair count and weight because it's hitting that crucial type 2 isoform in the follicle.
But the catch is you have to keep taking it.
Absolutely. Continuous long-term use is mandatory to maintain the effect.
And for a bigger impact, there are dual inhibitors like dutasteride, which hits both type 1 and type 2.
Correct.
Okay, shifting gears completely now. Let's talk about a very clinically sensitive topic. Using androgens in critical illness and wasting syndromes.
Yes, this is a real paradox. As we mentioned, critical illness, severe burns, trauma causes this rapid transient hypogonadism.
Because the HPG axis gets suppressed.
Right, and that leads to a profound catabolic state. You lose muscle mass incredibly fast, which hurts recovery and wound healing.
So we use anabolic therapy to counteract this. Anabolic androgenic steroids. T analogs like oxandrolone or nandrolone.
We do, especially in things like AIDS wasting syndrome or for severe burns where that anabolism is crucial for just surviving.
But there has to be a major caveat here.
Oh, a huge one. And it must be stated plainly. Despite decades of work, no anabolic steroid has ever been developed that is truly devoid of androgenic effects. We can't separate the anabolic from the virilizing effects.
So there's always a risk.
Always. And using them in severely ill patients demands meticulous monitoring because of potential adverse effects on the heart, on the immune system. The risk-benefit calculation is incredibly tight.
Finally, let's go back to the skin. Dermatology, acne, and hirsutism.
Classic androgen-dependent disorders. And the sebaceous gland in acne is, well, it's uniquely problematic.
Why is that?
Because it's a tiny, self-contained androgen factory. It has all the enzymes it needs, including the key type 1,5-alpha reductase, to take weak adrenal androgens like DHEA and convert them locally into potent testosterone and DHT.
Right there under the skin. So the anti-androgen strategies try to shut that factory down. You see topical AR blockers.
RU58841, yeah.
Yeah.
To hit the receptor right where it matters. Or you use systemic blockers like spironolactone or cyproterone acetate.
And the systemic agents are effective, but they carry their own risks.
They do. Spironolactone can cause menstrual irregularities. Cyprodone carries a risk of potential hepatotoxicity. So it always comes down to careful patient selection and balancing that need for systemic control against the localized risks. So to synthesize everything we've covered, androgen signaling is just defined by its pleiotropy. It is not a simple on-off switch. Its function goes from long-term genomic regulation of cell growth all the way to rapid non-genomic modulation of apoptosis.
So for you, the clinical learner, mastering this means what?
It means understanding the enzyme subtypes, the HPT axis checkpoints, and critically, the nuances of the AR domains and its oncogenic co-regulators. That knowledge is truly the difference between effective treatment and therapeutic failure.
I think the biggest takeaway today, the things that should really stick with you, is that testosterone is not the only active hormone here. Its clinical impact relies almost entirely on its conversion to two other molecules. DHT for local potency, and estradiol for systemic protection, especially for bone health. You can't treat T in isolation.
And to really solidify those connections, here's a final review question for you to think about. Surgical castration eliminates testicular testosterone, but prostate cancer often becomes castration resistant. So describe two distinct molecular mechanisms, one involving a genomic co-regulator and one involving a non-genomic receptor mechanism by which a prostate tumor could continue to thrive using either non-testicular androgens or growth factor signaling.
That brings us to the end of this deep dive into the androgen receptor system. Thank you for joining us.